Hello everyone, I'm Dr. Eric Wamwell. I'm a pharmacist and clinical assistant professor at UMKC's School of Pharmacy. I'm also a clinical pharmacy specialist here at Centerpoint Medical Center, specializing in infectious disease. And today I have Erica and Justin with me, who are both pharmacy students in their final year at UMKC as well. And we want to take some time to talk to you about a new antibiotic that was just recently approved called Avycaz. Name brand, trade name is Avycaz, and its particular indication is for resistant pathogens. And one of the things that we see from a medical standpoint right now is a big concern with resistance as it relates to gram-negative pathogens specifically. During the mid-2000s, the big concern was with gram-positive pathogens, specifically methicillin-resistant Staphylococcus aureus. Our large concern right now is resistance related to a couple of Enterobacteriaceae species, Escherichia coli and Klebsiella pneumoniae. And so that's what we're really going to focus on today, is how this drug provides us a real option for these types of resistant pathogens that are going to be effective potentially against superbugs that you may have heard of from 2012 related to the NIH outbreak or the recent outbreak at UCLA. So with that, I'll kind of let Erica describe resistance related to these pathogens and give us a little bit of information about Avycaz as well.
All right. So starting off with beta-lactam resistance, the main mechanism involved in beta-lactam resistance in Enterobacteriaceae is the production of enzymes, specifically the beta-lactamases, that possess hydrolytic activity against beta-lactamines, so the penicillins, the cephalosporins, monobactam, and carbapenems. The addition of avibactam greatly improves the activity of ceftazidime versus most species of Enterobacteriaceae, depending on the presence or absence of these enzymes. So what are these enzymes and what do they inactivate? So there are 4 groups of beta-lactamases, depending on their activity profile. The first one is penicillinases, which inactivate penicillins, but do not degrade cephalosporins as treonam or carbapenems. Next one is cephalosporinases. They preferentially inactivate cephalosporins and aminopenicillins, but do not affect other penicillins as treonam and carbapenems. Third one is extended spectrum beta-lactamases, or ESBLs, which I'll be referring to throughout the presentation. So those inactivate all beta-lactams except carbapenems. And then lastly is the carbapenemases, which inactivate at least carbapenems, and depending on the enzymes, other types of beta-lactam molecules. So looking at resistance trends, third-generation cephalosporins, such as ceftazidime, were originally developed to overcome resistance caused by common beta-lactamases. However, within a few years, hospital-acquired gram-negative bacilli like Klebsiella pneumoniae and others began producing mutated versions of the beta-lactamases that made them resistant to third-generation cephalosporins and to the monobactam as treonam. According to the National Nosocomial Infection Surveillance System report in 2003, 20.6% of all Klebsiella pneumoniae isolates from patients in ICUs in the U.S. were non-susceptible to third-generation cephalosporins. This represented a 47% increase compared with resistance rates for through 1998 to 2002. Non-susceptibility to third-generation cephalosporins was also observed in 31.1% of Enterobacter species and 5.8% of E. coli isolated from patients in ICUs in 2003. And according to the CDC, rates of Klebsiella pneumoniae carbapeneses, or KPCs, which I'll be referring to, producing organisms in particular, have increased across the country significantly in the last 10 years. So looking at carbapenems and carbapenem resistance, we know that carbapenems are currently considered to be the preferred agents for treatment of serious infections caused by ESBL-producing Enterobacteriaceae. Carbapenems are highly stable to beta-lactamase hydrolysis. Their susceptibility to most strains of Enterobacteriaceae makes them generally useful as treatment for multi-drug resistant organisms, but the expression of ESBLs plus loss of outer membrane proteins have been associated with carbapenem resistance in Klebsiella pneumoniae. In the U.S., carbapenem resistance has been observed in strains of Klebsiella pneumoniae producing class A carbapenemases, namely KPC1, 2, and 3. The genes encoding these enzymes are apparently obtained via plasmid conjugation, and the enzymes are capable of hydrolyzing and inactivating these carbapenems. KPC-producing strains have generally been shown to exhibit multi-drug resistance that includes zosyn, third and fourth generation cephalosporins, fluoroquinolones, and aminoglycosides, as well as carbapenems. So, now, for a long time, cephalosporins have been important agents in the treatment of many types of bacterial infections because of their broad-spectrum activity, well-characterized pharmacokinetic and pharmacodynamic properties, and proven safety and efficacy. However, due to the worldwide spread of ESBLs, KPCs, metallo-beta-lactamases, as well as the presence of chromosomal AMP-C beta-lactamases and gram-negative bacilli, has really kind of reduced the use of cephalosporins and has contributed to the increase in difficult-to-treat multi-drug resistant organisms. So that's kind of where Avycaz comes in. Avycaz was approved in February 25 of this year, and it's a fixed combination drug containing ceftazidime, which is a third-generation cephalosporin, and avibactam, which is a new beta-lactamase inhibitor. It was granted priority review and was eligible for the FDA's Fast Track program and a 5-year regulatory extension of exclusivity. Avycaz combines ceftazidime, a cephalosporin, with in vitro activity against certain gram-positive cocci and gram-negative bacilli, including Pseudomonas, and avibactam, which is a non-beta-lactam beta-lactamase inhibitor that inactivates certain key beta-lactamases and protects ceftazidime from degradation by these beta-lactamases. It is particularly active against Ambler class A, C, and some D serine beta-lactamases. So the addition of avibactam to ceftazidime protects ceftazidime from the breakdown by ESBLs, KPCs, and AMP-C producing pathogens. So what does it treat? So avibactam in combination with metronidazole is indicated for the treatment of complicated intra-abdominal infections caused by a number of pathogens of the Enterobacteriaceae family and Pseudomonas, and it's also indicated for the treatment of complicated UTI infections, including pyelonephritis, also caused by a number of pathogens of the Enterobacteriaceae family and Pseudomonas. So of significance, Avycaz also demonstrated the ability to cover extended spectrum beta-lactamases from a number of enzyme groups. These are TEM, SHV, CTXM, AMP-C, KPC, and certain oxalacylinases. Now, these are all different enzymes that a bacteria can encode for, and that will cause the production of ESBL production. And beyond ESBL coverage, Avycaz also has activity against Pseudomonas, but to note, has not shown activity against bacteria that produce metallo-beta-lactamases and may not have activity against gram-negative bacteria that overexpresses efflux pumps or have porin mutations. So, in the end, ultimately, avibactam's role is to broaden the spectrum of ceftazidime versus the beta-lactamase producing gram-negative bacilli. The exact roles of Avycaz will be defined by its safety and efficacy profiles, which Justin will go over next.
So I think what you did was provide us a really good broad look at these different resistance mechanisms that our gram-negative pathogens can encode for. And just as a reminder, there's kind of these different layers of resistance, different layers by which a drug may not be effective against a bacteria, whether it be penicillinases, cephalosporinases, extended spectrum beta-lactamases, or carbapenemases. So there's kind of these up layers of ACEs, or degradative enzymes, that can cause resistance among some of our antibiotics. And so this Avycaz particularly is very promising in its role for the top two layers, the extended spectrum beta-lactamases and the carbapinamases. So that's really exciting to hear because we don't have anything that's been shown to have really good regular activity against those type, particularly the carbapinamases, the superbugs. And so what, Justin, what have they found when we've looked at these in clinical trials then?
So I'll go into the two phase 2 trials that got Avycaz approved so quickly. The first one was published in 2013 in the Journal of Antimicrobial Chemotherapy. Basically, it compared the efficacy and safety of Avycaz plus metronidazole to that of meropenem in the treatment of complicated intra-abdominal infections. So it was a phase 2 prospective randomized double-blind trial. It was done in 8 countries at 33 different sites in 2009 from March to December. Patients were male and female, aged anywhere from 18 to 90. They had to have evidence of complicated intra-abdominal infection requiring surgical intervention, as well as an infection that was either caused or thought to be caused by a susceptible pathogen to the study drugs, based on the pre-study cultures that they drew. So patients were randomized 1-to-1 to receive either 2,000 milligrams of ceftazidime with 500 milligrams of avibactam every 8 hours, along with metronidazole 500 every 8 hours, or they received 1 gram of meropenem every 8 hours, along with saline solution to maintain blinding. So this was done for a treatment period of 5 days to a maximum of 14 days, depending on their clinical response. The only other antibiotics permitted were vancomycin, linezolid, and daptomycin for suspected or documented MRSA infection or enterococcal infection. The primary efficacy endpoint they looked at was the clinical response at a test of cure visit 2 weeks after their last dose of study medication. And this was done in what they called a microbiologically evaluable population. This was defined as patients who had a complicated intra-abdominal infection confirmed by operative findings. They had to have received anywhere from 80 to 120% of the study drug, had to have had sufficient information to determine a clinical outcome at the test of cure visit, and they had to have at least one clinically relevant pathogen that was susceptible to both groups isolated in their initial culture. So in this microbiologically evaluable population that was their study group, there were 68 patients in the Avycaz and metronidazole group and 76 patients in the meropenem group. And at this test of cure visit, what they found was that a favorable clinical response was seen in 91.2% of patients in the Avycaz group compared to 93.4% in the meropenem group. So this was an estimated difference of about 2.2%, which was found to not be statistically significant. Response rates were also generally similar between groups, whether the infections were monomicrobial or polymicrobial. There were also 43 patients who had pathogens that were not susceptible to ceftazidime alone at baseline. 26 of these patients were in the Avycaz and metronidazole group, while 17 were in the meropenem group. And it was noted that all except 2 of these patients achieved a favorable microbiological response, and this was 1 in each treatment group. As far as safety, adverse events were observed in 64.4% of patients in the Avycaz group and 57.8% in the meropenem group. Most of these were mild or moderate in intensity and similar in frequency between the groups. However, they did note that nausea and vomiting, as well as abdominal pain, was seen more in the Avycaz and metronidazole group. Serious adverse events were noted in 8.9% of patients in the Avycaz group versus 10.1% in the meropenem group. However, there was only 1 event that was actually considered by the investigators to be related to the study medication, which was elevated liver enzymes in 1 patient in the Avycaz group. There were 5 deaths in the study, 3 from the Avycaz group and 2 from the meropenem group, but none of them were considered related to the study drug. So as far as what you can draw from this study, it was a study that had a small sample size, and they didn't have a formal calculation of sample size as it was the first study for Avycaz in this population. But you still can draw some conclusions. Basically, it may be an effective treatment for complicated intra-abdominal infections. It had a similarly favorable response rate to meropenem. And then in those patients that did have ceftazidime-resistant infections, it did show improvement there as well. So potentially for those extended spectrum beta-lactamases. And then also another limitation of the study, though, was that a large proportion of the gram-negative isolates in the study were E. coli, and only a small fraction of them were those ceftazidime-resistant pathogens, as well as the Apache 2 scores of 80% of the patients were less than 10, which would be an indicator for non-severe illness. So the applicability of this trial to severely ill patients may be limited. So I'll go ahead and jump into the second trial now that helped Avycaz get approved quickly. This was a 2012 trial published in Current Medical Research and Opinion, and it compared the efficacy and safety of Avycaz to imipenem and cilastatin for the treatment of complicated UTIs, including acute pyelonephritis. And this was a phase 2 trial, prospective multi-center double-blind trial. It was at 26 centers in 5 countries from November 2008 to June 2010. Again, male and females aged 18 to 90, and they were diagnosed with either acute pyelonephritis or other complicated UTI that was due to a gram-negative pathogen deemed to be serious by the investigator. Patients were also stratified based on their infection type, either acute pyelonephritis or other complicated UTI, and then randomized 1-to-1 to receive either 500 milligrams of ceftazidime with 125 milligrams avibactam every 8 hours, or 500 milligrams of imipenem and cilastatin every 6 hours. Treatment with the study drug was for 7 to 14 days, but patients that showed clinical improvement after at least 4 days of IV therapy and had pathogens that were susceptible to both drugs were allowed to switch to oral ciprofloxacin for their remaining treatment course. They were excluded from the study if infection was caused by a pathogen known to be resistant to one or more or one or both study drugs. And this trial also, just like the last one, the primary efficacy endpoint was a favorable microbiological response at a test of cure visit, which was done 5 to 9 days after the last dose of study drug in the microbiologically evaluable population as well, which in this study was defined as patients who had no major protocol violations, had a positive urine culture, or on enrollment that was presumed to be susceptible to both study antibiotics. They had to have had a clinical and microbiological assessment at the test of cure visit, and to have received at least 7 days of study therapy or were classified as failing after at least 48 hours of therapy. This population in this trial included only 27 patients in the Avycaz group and 35 in the imipenem cilastatin group. And at this test of cure visit, favorable response was seen in 70.4% of patients in the Avycaz group, while the same response was seen in 71.4% in the imipenem cilastatin group. So similar between groups again. They were also similar, the results were similar when stratified by diagnosis, so either acute pyelonephritis, which in acute pyelonephritis, the response rates were 72.2% for Avycaz and 73.7% for imipenem cilastatin, respectively. Similar there. And then for other complicated UTIs, the response rates were 66.7% and 68.8%, respectively. In cases where E. coli was isolated, 76% of patients in the Avycaz group and 69.7% of patients in the imipenem cilastatin group achieved this favorable response. In terms of ceftazidime-resistant pathogens, favorable response was seen in 85.7% and 81.8% in each group, respectively. So again, effective against those pathogens that might have those extended spectrum beta-lactamases. In terms of safety in this trial, the most common adverse events in both groups included constipation, diarrhea, abdominal pain, headache, anxiety, and injection site reactions. Adverse events were reported in 67.6% of the Avycaz patients and 76.1% of patients in the imipenem cilastatin group. Serious adverse reactions were noted in 8.8% and 3.0% in these groups respectively. There were 3 serious adverse events considered to be related to Avycaz use, which included renal failure, diarrhea, and they actually accidentally overdosed someone, although there was no other adverse events associated with that overdose. So the results of this trial also provide some evidence that Avycaz may be efficacious or as efficacious as imipenem cilastatin for the treatment of complicated UTIs in adults. It also appeared to be generally tolerable. Some limitations, again, are the small patient population size, the small percentage of patients with a pathogen that was actually isolated at baseline, and the fact that there were very few patients with ceftazidime resistant and Pseudomonas infections. And then just a side note also, there have been 2 larger studies that have since compared Avycaz to doropenem in complicated UTI, but the results are not published yet. But what you can take away from these 2 trials in general, basically looking at the efficacy and safety of Avycaz, we do have some evidence showing that it may be a potential candidate for use in a variety of these multi-drug resistant infections that are becoming more of a problem worldwide.
Great, thank you. So, yeah, I think it's what might be surprising to listeners or viewers of this recording is how small these trials are and how small the amount of data is for this now FDA approved drug. And this is the first drug to be approved with phase 2 trial data only. This is really underneath that GAIN Act, that Getting Antimicrobials to Market Quicker Act that was approved over the past few years to really get drugs to market for resistant pathogens. And so that's really what pushed this drug forward, is the fact that we've got some decent safety data, we've got some decent efficacy data for a pathogen that we really have nothing that has been proven to be efficacious for. And that's where Avycaz is really going to have its niche, is with these carbapenemases, particularly and specifically the Klebsiella pneumoniae carbapenemases, which is the only spectrum of carbapenemases that's been shown to be effective in. Which is good, which is fine. That's the most common form of carbapenemase that we're seeing in the United States. So really a promising drug. Still a lot of questions associated with this drug, but a lot of promises. And one of the things that you'll note if you look at the indications for Avycaz is that it's for microbiologically susceptible, resistant intra-abdominal and complicated urinary tract infections. That's kind of the caveat to its approval, is that they're microbiologically susceptible. So if there is an extended spectrum beta-lactamase or carbapenemase that comes back positive on your patient, you'll want to look at the microbiologic susceptibility pattern for this drug specifically. Another just caveat off of that is if your patient does develop a carbapenemase that's a urinary tract infection, one of the other options that you'd likely want to consider is phosphomycin, which is a urinary tract specific agent that's been shown to maintain about 80 to 90% susceptibility to these more resistant ESBLs and KPCs, but it only achieves concentrations in the urine. So that would maybe be your first line agent, and then reserving this agent for bacteremias or intra-abdominal infections where it's been shown to get systemic concentrations, tissue concentrations. Yeah, so an exciting time in regards to trying to take out some of these super bugs, right? Trying to develop some. What is it that Superman is susceptible to? You guys know? Kryptonite. So like we've got some kryptonite against the super bugs now, hopefully. But with that, we thank you for your time today. Hopefully we were able to provide some information that will help you as you approach patients with resistant pathogens, as you take a look at this new drug, Avycaz. Yes? All right. So that's signing out.